Good morning, Charmaine Robinson.
Welcome, welcome, welcome. All right. Welcome to Inclusive Healthcare's kickoff meeting, task force kickoff meeting. Before we get started into the meat of our convening today, I wanted to state a couple of things. My name is Fayana Richards, and I am affiliated with MPHI, and I will be sort of popping in and out, sort of keeping the flow of things going as you move between different components. So the purpose of today's meeting is to sort of launch the task force to bring together public and private sectors in Detroit. A couple of tech reminders. We are welcome to your questions. So if you have any, please use the chat function on the side of the screens. If you have any particular questions, and we have individuals keeping an eye on that. So please post your questions throughout today's meeting if you have them, and we have a designated Q&A towards the end of the session. Second, please keep your mics muted. This helps sort of with the, so that way we can hear the panelists speak. And three, we'd like you to know that this meeting is being recorded. Please feel free to message me or Philip if you have any issues with that. Next, I would like to introduce our first speaker, Dr. Alexis Travis.
And this will require just a slight change in formatting as I bring up Dr. Travis's PowerPoint. So Dr. Travis, if you want to just step into the space and introduce yourself, I'll bring your PowerPoint up in just a second.
Yes, good morning, everyone. It's such a pleasure to be here with you amongst friends and colleagues this Friday morning in my new role as Senior Deputy Director of the Public Health Administration at the Michigan Department of Health and Human Services. This morning, I'm going to talk to you a little bit about social determinants of health. I'll explain the impact that they have and our broader department approach, and then some of the things that we've been thinking about in terms of integrated and coordinated care and next steps that folks can take to support this moving forward. Phil, are you ready with the slides?
Almost. Can you hear me?
Yes, I can.
Almost. Sorry, just 1 second.
That's okay.
Share my screen.
So I can start off by just telling you a little bit about social determinants of health. And next slide, please, Phil. So these are the conditions in the environment where people are born, live, work, learn, play, worship, and age. And they affect a wide range of health, functioning, quality of life, health outcomes, and risk factors. Many people are surprised to learn sometimes that 80% of what determines our health actually happens outside of their doctor's office. It's non-healthcare factors. This is 30% our behaviors, 10% our physical environment, and then 40% social economic factors, including education, jobs, family supports, income, and community safety. Next slide, please. So why does this matter to us? It's really important for our general health and wellness. And when we look at the community in Detroit, we know that social determinants of health have led to inequities in Detroit, and that's seen in sometimes the health outcomes that we see. Some examples are inequity in food access across areas in Detroit. You might have heard the term food deserts, where areas where people don't have access to healthy foods in grocery stores, or food swamps where there's just an abundance of unhealthy food. Think of streets that you drive down where there's, fast food chains and there isn't really any access to fresh fruits and vegetables in local markets. These are linked to dietary practices because if people don't have access, they're not going to be able to eat the healthy foods. Another example is air pollutants and the impact that they have on blood pressure. And we see this in Southwest Detroit, and those data come from the National Institute of Environmental and Health Sciences. And then lastly, the poverty rate in Detroit of 35%. Poverty impacts so many different things, but one substantial area is the impact on housing and where people are able to live. And this can have a specific effect on health as well. And then, the disproportionate impact of social determinants of health more broadly on communities of color. And we see that in the various inequities as well. Next slide, please. So here you can see, on the next slide, you can see our environments cultivate our communities and our communities nurture our health. And I really like this visual because as you can see, the soil is where the nutrients come from. So if you've got rich soil, you get a good sturdy tree. If you've got soil that is poor in nutrients, you don't get a good tree, you get a tree that is limp and not very bountiful. So you can see things like poverty, poor school quality, segregation, tobacco, alcohol, lots of things can lead to poor community outcomes in terms of, these inequities and low assets and worse health outcomes. You could see higher rates of obesity, depression, heart disease, abuse, and violence, smoking. And then when you've got the rich soil where you have quality schools, you have access to care, you have clean environment, you have jobs, you'll see that the health outcomes, because the community structure is better and that health supportive factors are there, you'll see lower rates and more manageable health outcomes. So you can see like less malnutrition, you'll have hopefully less smoking, you'll have a better community feeling and presence. You may even have lower obesity rates. And these again go back to those social determinants of health, the economic stability, the neighborhood, the built environment, education access, food security, community and social context, and then healthcare access and quality. So on the next slide, here I just want to outline the MDHHS approach to social determinants of health. And this is so important that we have centered social determinants of health in our department's strategic plan. So one of our goals is to address food and nutrition, housing, and other social determinants of health. And the way that we're doing this, we're putting this into action across our department, is by putting health in all policies as a primary objective. We're also working with community-directed priorities, and this involves engaging the community, listening, and then using that input to get upstream and address the social determinants of health. We're using data to drive our approach and drawing insights on inequity to better target our interventions to meet the needs of the people that we serve. We're auditing our health and human services programs. We're using a health equity lens to remove systemic barriers to reduce disparities and improve health outcomes. And we're strengthening our home visiting programs. This is particularly important to reach people where they're at, to screen, to provide close loop referral services, and to enroll individuals to other services that we have, for example, food assistance programs, which is something the department is responsible for. And then lastly, we're working collaboratively across other departments, for example, the Department of Labor, Economic Opportunity, to ensure strategic priorities on housing are aligned as well. Next slide. So in terms of the broader aspects of the healthcare system and the importance of integrating our coordinated care, it's really important that we address the needs of the whole person. And so I talk about a 360 approach when we're talking about the impact on health outcomes. Healthcare systems can connect vulnerable populations to resources and services. What does this look like? This could be making sure that people have healthcare coverage, making sure that there are available providers, and that the providers that are available are able to connect culturally with the community that they serve. Also providing linguistic and other aspects of cultural competency, and then supporting the quality of care, whatever that means for the patient. A lot of this surrounds removing barriers to access, including providing transportation, navigation services, and in-home services, for example, when we're talking about older adults. We want to take an integrated and coordinated care approach for linking patients to the resources that they need for more effective treatment plans. And then lastly, overall, we want to improve health, living, and working conditions. I want to just draw your attention to some recent successes, though, specifically looking at the aging network. And this is something that DAAA and Mr. Taylor were particularly instrumental in implementing when it comes to social determinants of health. First of all, we were able to partner with the Food Bank Council of Michigan during the pandemic to address food insecurity and access to food. And so we were able to provide quarantine boxes, which were boxes of shelf-stable, nutritious foods that were delivered to older adults where they were, so that they did not have to go to their grocery store and they could receive food at home. And this was something that was really taken up in a big way by older adults in the early stages of the pandemic. Another thing that we recognize is that older adults were at higher risk for social isolation, and this got even worse during the pandemic. So we were able to partner with Get Set Up to have older adults teach other older adults how to use various forms of technology as part of an online community. So there's an opportunity for us to be creative as we think about the social determinants of health and how we can best meet people's needs. So moving forward, what is our community approach to social determinants of health? Well, the Michigan 2020 Health Equity Report really gives us some good next steps and action items, continuing to address social, economic, and environmental conditions to ensure that Michigan's racial and ethnic populations have essential resources that they need to improve health and advance equity, investing in building family resilience, improving access to services, and uplifting educational opportunities, and also thinking about addressing social determinants in ways that are in alignment with the community where people live, work, and play. And so this is really that concept of community voice. Promoting social determinants of health is a top priority for community organizations, healthcare systems, and government agencies at all levels. So that requires a lot of collaboration. And then lastly, implementing focused collaborative efforts that include long-term interventions and investment in addressing social determinants of health. And that's really also where our budgets come in and making sure that those resources are available to do the work that we need to do. So I know I didn't have a lot of time to talk with you this morning. I'm going to leave it there. Welcome any questions that you may have. Thank you.
Thank you, Dr. Travis, for that excellent commentary on social determinants of health and the importance of integrated care. Next up, once the slides are up, I will be introducing Dr. Herbert Smitherman, who will be giving an overview of the Dying Before Your Time report. So Dr. Smitherman is the FACP Vice Dean, Diversity and Community Affairs Professor of Medicine and Carmona's Cancer Institute at Wayne State University in the School of Medicine, and as well as the Detroit Medical Center. They are the president and CEO of the Health Centers of Detroit Foundation, and they are also the lead author of Dying Before Their Time. And they will now give a brief overview of the Dying Before Your Time report. Welcome, Dr. Smitherman.
Thank you. So this was a critically important initiative in the city of Detroit that was brought to Wayne State by DAAA, really around a simple concept, and that was that they anecdotally noted they were losing seniors, and there was a need to understand why the Detroit area actually lost 23% of its seniors between 1990 and the year 2000, and determine the factors associated with this loss. Was it because seniors were leaving and this was out-migration? The experience of DAAA felt that was not the only cause of this, because obviously prices were high in the suburbs, and many of the seniors in Detroit were on fixed incomes. And we wanted to know and understand the role of health status and the role that health status played in the loss of the seniors. Ultimately, we found that not only were we losing seniors, most of that loss was in the younger age group, younger seniors. In fact, even the pre-seniors. We found that death rates for the Detroit area, older adults between age 50 and 59, for example, were about 122% higher when compared to the rest of Michigan. And seniors between age 60 and 74 were about 48% higher than the rest of Michigan. And ultimately, we found that just over a third of all the losses of these seniors was really due to increased death. We also found that there was about a 37% higher hospitalization rate in the seniors. And with respect to morbidity, at least 89% of the seniors in Detroit had at least one chronic illness. 39% had 3 or greater. And 54%, or most of the seniors in Detroit, lived in medically underserved areas. So as this slide indicates, the older adults in Detroit were dying at 2 to 2.5 times the rate of older adults in the remainder of the state. Older adults exhibited a much poorer access to care. In fact, this was a study between the years of 1999 and 2017. And over that period of time, there were 3 iterations of this analysis. And we went from 54% of the seniors living in medically underserved till finally in 2017, we noted that 65% of seniors lived in medically underserved areas with insufficient access to health professionals. And we've already talked about the issue of multiple chronic illnesses, increased access to hospitalizations, et cetera, and the need to rely more on social determinants of health, food, transportation, et cetera. Next slide. So I think largely, the issue is there is a significant gap between Detroit and the rest of the state of Michigan in all of these metrics that I've talked about. And I think the real issue is that if you look over time, comparing the first report to the second report to the third report, we have not seen an improvement. And in fact, in many areas, we've seen widening of the disparities and increasing mortality, increasing hospitalization, and an increase in the number of seniors living in vulnerable communities. So I think the concern, especially related to the DAAA organization, was as we are documenting this and we are seeing this now over a 17 to 18 year period of time, and the conditions are worsening, we have not invested the kind of resources or begin to bring together the collaborative resources to try to have a significant intervention. I mean, the concern is just watching this is probably not what we should be doing at this time, and we need to invest in an intervention to make change. Next slide. Okay.
Thank you, Dr. Smitherman, for your comments on the Dying Before Your Time report. Next up, we're going to segue into a moderated panel that will be moderated by Dr. Renee Kennedy. Dr. Kennedy has been recognized as a national thought leader in the areas of health inequities and disparities, cultural competence, and social justice. They have published and presented broadly on these topics, and her passion for this work is evident in her personal, academic, and personal life. Dr. Kennedy has been highly influential in broadening the discussion of health equity and social justice while serving on numerous national boards, review panels, and advisory groups. They are the Chief Executive Officer of Michigan Public Health Institute. Next slide, please. So first up on the panelists is Dr. Paula Cunningham, who is the State Director of AARP Michigan, which has more than 1.3 members. AARP is a nonprofit, nonpartisan social welfare organization with a membership of nearly 38 million. They work to lead positive change and deliver valuable to all people over the age of 50 and up. Welcome, Dr. Cunningham. Next up, we have Ronald Taylor, who is the President and CEO of DAAA. Ronald Taylor is the servant leader who believes in meeting in the highest priority needs of others. They see the common good and work to serve it. They believe in developing the full potential of employees, connecting them to a shared mission, and exceeding the expectations of those participating in the programs of the DAAA. As president and CEO of DAAA, Taylor leads an agency of 150 staff members with an operating budget of $73 million. DAAA, one of the 16 area agencies on aging in Michigan, serves over 90,000 seniors, caregivers, and adults with disabilities annually, including the largest minority population of older adults in the state. Welcome, Mr. Taylor. Next slide. Okay, so now I would like to reintroduce you to Dr. Kennedy, who will be moderating a series of questions to our panelists. Welcome, Dr. Kennedy.
Thank you, Dr. Richards. I would offer, Phil, that we can unshare the slides. I do have the questions, and that way we can see everyone's face. I mean, we're so energized by your presence. You know, we sometimes say a lot of our sort of African proverbs or sayings with some cliche, but it is indeed going to take this village and more to reverse the pattern that Dr. Smitherman just shared with us. It is just amazing that although life expectancy is increasing in our country, it is not increasing equally for all people. And we know that Black and Brown citizens are dying at much higher rates, as we heard from Dr. Smitherman. At a board meeting yesterday, I learned that the life expectancy of Black women today is what the life expectancy of white women was in 1970. So Black women are increasing, but we can't look at the trend and say, well, things are looking better. It's the type of analysis that Dr. Smitherman has provided that lets us unpack the story. And so we want to unpack the story a little bit more with colleagues who have spent their careers advancing change in this space. And I'm so happy to be a part of this dialogue. And let me start with this idea of kind of who's at the table. Many of us are in public sector, even universities can be considered public or private sector, but there is this need for cross-sector collaboration, both private sector, public sector coming together to address these disparities, and even especially the technology gap, which is both an availability gap as well as a knowledge gap. So let me start with Ms. Cunningham, because she has been a successful leader in multiple sectors. And Paula, tell us a little bit about your thoughts around public and private collaboration to impact these disparities.
Thank you and welcome. And I'm just honored to be a part of this panel and appreciate all of you who are on the call. This is not about just 2 or 3 or 4 or 5, 6 people, but it is truly what Dr. Kennedy said. It's about the village. And so as part of that village, some of the work that we have seen in terms of the public-private sector collaboration, I can share with you that just about everybody that's talking or speaking to you today, AARP has engaged with in some way or another, not just the nonprofit sector, but also the private sector as well. And that seems to be the way to move forward today when you're looking for grants, when you're going after any kind of funding. But quite frankly, it's been a part of my DNA for years and years and years, because I'm not limited by my own intelligence. I believe that you get more people in the room, the more you grow, the more you develop. And that includes folks from all walks of life, not just those who lead organizations. We've done a phenomenal partnership with Wayne State University. We've done partnerships with Western. We've done partnerships with General Motors and with Ford. And so we've done lunch and learns inside of those organizations. As a result of that, you collect some measurements, some data, some metrics, and then you go after grants. You can help each other in that way. So I believe that it is not only a wave of the future, but it is a way that we can elevate our own work, that way that we can become smarter and more intelligent and more knowledgeable. I've already taken some notes just based on what I've heard from Dr. Smitherman, Dr. Travis, and Dr. Kennedy. I mean, I've got notes right here that I just took as a result of that. So when you get more people in the room, when you get more people and you're listening, not talking all the time, but you're listening to their needs, to their wants, to their desires, that's when real change can occur. And it really does take an entire village to make that happen.
Absolutely. Dr. Smithman, you've worked in the academy, but you're also a practicing physician, which takes you into another sector. Do you have thoughts about how private and public entities can come together toward this shared goal?
Yeah, I think, as has been presented here, we have an understanding, and there's increasing awareness that social determinants of health affect physical and mental health outcomes. And I think ultimately we need to design and implement a social determinants of health project of some kind to help screen our clients, our community members, our families for social needs, and have a mechanism to refer them to community partners. And if we're going to be able to do that, community partners must come together. And as was said in the earlier presentations, we must link our community or our clients, our patients, et cetera, with resources. And we've got to, I think, move from some of the more fragmented nature of how we do business. We have, people that are involved in transportation, some are involved in employment, some are involved in education, food security, housing security, affordable childcare, issues of how we do cleanup, everything from lead exposure to asthma triggers and workplace safety issues, and all of these kind of issues that all of us deal with in our own realms. But I think we're all kind of siloed. And so how do we bring those silos together with respect to some level of a council that that we could address our community's needs in a more holistic way? So if who's ever dealing with housing, if I have a patient in my practice who has significant housing insecurity that's clearly impacting their both mental and physical health, how do we link that person to the housing resources or potential housing resources? And how do we also expand those resources to make sure they're at a level that can address the needs of those we see every day?
I love that in so many words you've affirmed we are our brother's keepers. And so we can't just stay in our little narrow lane saying, this is what I do, leave me alone, I don't do that. But how do we really come together and partner? Love it. Mr. Taylor, I love that your bio describes you as a servant leader. A really, really important principle that is near and dear to my heart. And you're in the throes of this. And this is about Detroit and Detroiters. So talk a little bit from your heart about what types of things, implementations, interventions you would love for us to see, love to see from us as we coordinate and integrate our response to social determinants of health.
Yeah, thank you, Dr. Kennedy. And I'll also like to just say thanks for all my panel, to all the fellow panelists, and also to everyone that's participating in today's conversation. This is a critically important conversation, and it's one in regards to where, as Dr. Smitherman and yourself has said, and also Ms. Cunningham, it is really going to be a collective effort in regards to us trying to make a collective impact in regards to addressing issues and the needs that our community is facing. Some of the activities and some of the things that we, from our organizational perspective, that we see that needs to be addressed. And I have to give credit to my predecessor, Paul Bridgewater, who has implemented some of these initiatives already. But the ability to provide health promotion and evidence-based programs to assist individuals in regards to whether it's, say, diabetes, or if it's hypertension or any other chronic illness, to try to readily address that. And so we've been working with some of our partners to really get programs and services like this out there so that we can touch as many folks as possible. I also believe that some of the things in which we really need to do and which we need to examine, and is we really, Dr. Smitherman spoke about the prevalence of chronic illnesses amongst the older adult population. And so one of the things in which we always think about is that what we're really doing is we're treating the diseases. But we need to do more in regards to where we're preventing the diseases. So in order for us to do that, we really believe that there's going to have to be some work that's done across the lifespan in regards to working with individuals and educating individuals and about healthy lifestyle living and what they can do to avoid some of the chronic illnesses that they may encumber or they may face. We also feel like, from some other perspectives, that there needs to be continued dialogue as far as at a higher level or at the state level. And I'd just like to say thank you to Dr. Travis. Dr. Travis has been an ally and a key component and a key advocate for addressing some of the inequities and disparities in which our communities face. And one of the things that came about, and I really will promote this as we go forward, is that with the COVID situation, there was an element that was brought forward in regards to the social vulnerability index, and regards to where they were providing resources and fundings based upon the various community needs or some of the social determinants of health issues that a community may face. And I believe that as we continue to move forward, that some of our funding allocation systems need to integrate elements such as the social vulnerability index in regards to providing resources to the communities that they serve. So those are a couple of things that I would offer, but we're continuing to do things to help address the access to care by implementing programs such as telehealth, and also continue to work and to try to bring various partners together so that we can begin to come to the table and to have these conversations and to break down these silos and to recognize that we need one another if we're truly going to address and respond to the issues that are facing our communities.
Yeah, I think absolutely. The very fact that we are who we are in this conversation, right, speaks to our efforts in this initiative to break down silos. You know, Paula has numerous resources as our state director of AARP. You have numerous resources, Dr. Smitherman, but we're being intentional about saying, what can we do more of if we all came together? So I really appreciate that. I'm thinking a little bit, Dr. Smitherman, about the tension around what really creates health. And we really, I think in many ways in this country, miscategorize that. We get stuck on if people would just eat better and if people would just walk more. But you talked a little bit about really what creates health and well-being in your remarks. Can you talk a little bit more about that in terms of our efforts to eliminate the health disparities? What really creates health and how can we live our lives differently as a community?
Dr. Smitherman, you're muted.
Sorry about that. I've been lecturing on, health disparities for, 30 years. And several years ago, I said, I'm going to stop because it actually becomes depressing continuing to watch all of these health indicators continue to worsen, whether it's housing and schools or have been resegregating in the United States, or overall poverty rates have essentially remained the same. In 1968, poverty was 12.8% in the United States. And in 2016-17, it was 12.7%, essentially unchanged. American children living in poverty, have increased from 15% to 21%. The poverty rate is increasing. And we continue to see, whether it's incarceration rates, whether it's life expectancy. I can tell you life expectancy for whites was in 2015 was about 7 years higher compared to blacks, and it's 6.5 times higher in 1967. So, we all know these health gaps have been worsening over the past 60 years. The real issue is, what are we going to do about it? And I just believe that the only way that happens is a collaborative. There's a lot of resources sitting at this table today, and within this panel. And the question really becomes, what can we do in a collaborative way, sitting at whatever we want to call it, a council table or whatever, to really effectively make change. And that change has to be coordinated. It has to link our resources to people in a real way. It requires coordination, collaboration. It requires some infrastructure, so it links us together in some kind of glue. But I just think all of us individually do a great job. I just think if we could all come together and sort of pivot and begin to link our resources, coordinate our resources. And also, as we found in our study, we're seeing that a lot of this illness and disease is occurring in our society at an earlier and earlier age. In fact, we're starting to see significant obesity, diabetes, and hypertension in children. But we actually saw age for senior adults between age 50 and 59. It was the largest percent of death rates, 122% death rates compared to seniors or people age 50 to 59 in the rest of the state. And so I think DAAA and Ron Taylor, Paul Bridgewater always talk about moving upstream. examining the lifespan. When should we be starting our interventions? If most of this illness and disease is occurring in the 40s and 50s, and by the time they get to the 60s and 70s, we've locked in, we may need to move that lifespan earlier and intervene in an earlier way. But the only way we're going to really accelerate, amplify what we do, it's going to have to be synergistic. It's going to have to be us coming together to do that.
Well, absolutely. I'm actually encouraged by, as I sort of span those on camera in attendance today, I see what I'm going to conclude is a variation in age spans, right? I mean, we talk in sociology about racism not being a problem of Black people, Black and brown people. If it was only Black and brown people's problems, Black and brown people would have fixed it. It's like, this is killing us, let's fix it. Same thing with the problem around aging. If it was just about older adults, seniors saying, well, let's fix this situation, we would have fixed it. And so how do we begin to see this? I love that as a continuum. How do we begin to value age and aging when we're younger? But we know that change happens, right? I'm privileged to serve on the governor's coronavirus task force and on racial disparities. And we minimize the gap, the Black gap in coronavirus infection and disease in the Detroit area. We decreased, almost eliminated that gap, but it takes vigilance. So now we're seeing it tick back up a little bit, but we know that change happens. And so I say that with great passion, because the facts that you've shared with us, the statistics that you've analyzed are not self-fulfilling prophecies. They are alarms that you're sounding to say, what are we going to do to make things different? And I appreciate that it's tiring to simply talk about it. And this group, this coalition is about action and change. Dr. Richards, have people put questions in the chat. I want to try to engage our
Yes.
attendees halfway through.
Okay, so we have a question from Steve Evan, who asks, what efforts to coordinate care across silos are the highest priority for this group? And what initiatives have started? Changes in system design.
Anybody want to grab, what's a success? Can we think of a success?
This inclusive task force is just getting started. We're just launching this. And when we first had this idea, I think the four of us and others were on the call just talking about this. And it is really what the title of this task force, inclusive, is really what we are all about. We did a big AARP did a disrupt disparities report. We talked about technology disparities. We talked about financial security disparities. We talked about education disparities. We shared, there were 32 people that were involved with the reporting that went into that task force. As a result of some of that, I think the AAAs and others got a grant from MPHI and said, let's pull everybody to the table, like Dr. Smitherman is saying, and figure out how we can bridge this gap. I'm with Dr. Smitherman. I'm the oldest person on this panel. I know I am. And I'm sick of this. And so I would not say yes to being a part of this task force if I didn't believe that these are the people who can help bring about the change that we've talked about. So yes, there's a lot yet to come, and we are rolling up our sleeves to figure that out. But all the things that you just heard today about being inclusive, bringing transportation, bringing the private sector, and bringing others to the table, that's what we're about.
Thank you. Mr. Taylor, thoughts?
I was going to echo what Ms. Cunningham said, but also, one of the examples that came immediately to my mind is in regards to some of our activities and some of our work with our faith-based entities to really try to address issues around like dementia, or how to provide caregiving support for individuals that may be dealing with a stroke or have cancer, or any of those chronic illnesses. And and I think that's one of the biggest issues that we also need to focus on and talk about is in regards to the role of caregivers, whether it's formal or informal caregivers, and the support in which they can provide. So the work has begun, but I think the issue that has been raised is in regards to each of us are doing our own little things, but how are we going to collectively and to come forward to help change the systems, to help change, to have a collective impact, to really move this needle in regards to addressing some of these social determinants of health that our population faces. We're also working with the Detroit Food Policy Council to try to see what strategies can come forward in regards to addressing some of these food inequities that we see. But it's kind of like we're throwing rocks in the ocean if we don't, come together to collectively utilize our resources to address that. So, those are a couple of initiatives as far as collaborations, but I do believe that this conversation is kind of the start for us to build a roadmap and to develop what our strategy and what our approach should be.
I love, go ahead, Paula, unmute, please.
Give you a very quick example of how that can work. AARP, the Build Back Better legislation, everyone knows and has heard about Build Back Better. There was nothing in that legislation that talked about lowering the price of prescription drugs for older adults. Nothing. It's been something that we've talked about for 20 years. You can go to Canada and get the same prescription for less than you get it here in the United States. AARP galvanized their entire community across the country. 900,000 phone calls were made to legislators. Over 30,000 emails were sent to them. And within 24 hours, that was put into the Build Back Better legislation. That's what happens when you pull a community together, when you people are on it. And I always use this quote that united in our gifted in our many talents, we can unite in a common goal. We all have talents. We all have something to bring to the table. When we unite in a common goal, you see action like that, whether it's on the advocacy side, whether it's on the transportation side, public, private, or nonprofit. We can make things happen. We are the change that we want to see. Michelle Obama said that. We are the change that we need to see. It happens with us.
Yeah, I love that. I'm probably going to mess up this Frederick Douglass quote, but it's something like power releases nothing without a demand. Mm-hmm. And we are coming together to make a demand. Mm-hmm. And really, Mr. Evans, that question is so important because it's your thoughts. It's each of your thoughts coming together about the direction. We're tilling the soil, but we're planning on bringing harvest to flourishing trees, not like that dying, dilapidated tree that Dr. Travis showed us in her slide, but one that flourishes. Is there another question? And then I have a couple more questions for our panelists.
Yes, there's one by Winona Bynum. I was so excited that this task force exists and that this conversation is taking place. Can you talk about how you are getting the voice of the community members that your efforts impact into the solutions that you designed? And are you using any equity tools to measure your efforts?
Wonderful question. And as Ms. Cunningham said, this is the start of the dialogue, right? We believe that facilitated dialogue is a methodology for action, a methodology for change. And so we're hoping that that question might even lead your participation in the initiative, because we're going to be talking about how do we do community engagement, whose voice, how do we elevate voice, right? How do we affirm and legitimize concerns, not because of positions that people hold, but because of the lives that they're living and their own inherent expertise. So that's my thought on that. Other thoughts on how we'll be affirming voice in this process? Dr. Smithman, you've done a lot of community engagement. What methods have you used?
Was that for me, Dr. Smith? Mm-hmm. Oh, yeah. I first of all, I think it is the question is critically important. I always say, obviously, our end users must be a significant part of the collaborative, because that's where feedback comes. That's what helps shape whatever the intervention is or interventions. I also say it's very important that you establish measures and metrics to monitor the outcomes and the progress of any initiative that you do. You can't just sort of go out there and just sort of say, we're going to do good. We have to have targets. We have to have goals. We have to have measures. You have to have metrics. We want to know when we're strategically achieving our goal. And we need to implement system change that's driven by that data. So as the information comes in, we use that to modify what we do as a collaborative. So that's the way I would answer that question.
Absolutely. And you also asked Winona about how we intend to incorporate issues of equity. And I'll submit to you that certainly at MPHI, the lens with which we lead is that of health equity and justice in our work. And I know that is true for each of my colleagues here. So there is an intentionality that we bring to the work that you really can't do it authentically without addressing issues of inequity, racism, classism, ageism, all of those things that are barriers to each of us being our healthiest and best selves. Peeping. Yes, I'm liking Winona's comment about willingness to recruit community members. So I really, really appreciate that. So as we're drawing close to our time for the next agenda item, I want to, there are so many doors or messages that we get that I would categorize as sort of why bother messages. This is too hard. Why bother? Y'all are doing okay. Let's, so I want to offer to us that we need to lose our why bother and be real clear about our why. Like, why are we doing this work? Why are we pressing through the heavy lift, through the frustrations? And I just want to ask my colleagues to talk a little bit about your why. Why are you in the business that you're in right now? How has your journey brought you to this place? Can I start with you, Paula?
Absolutely. This is an easy one for me. People often ask about what inspires you. I've had so many different jobs. I'm still trying to figure out what I want to do when I grow up. But every place I'm going, I'm learning, I'm expanding. And the inspiration for me is that every place I go, my parents have never been able to go. Every place that I go, their ancestors have never been able to go. If I'm a member of a country club, or if I'm a member of the only woman who's president of a majority-owned bank, they weren't able to do that. I didn't get there on my own. The price has been paid over and over and over again. Think about Mary McLeod Bethune, who took bark from a bayberry bush just to make a pencil. And you don't want to go to school, and you don't want to learn, you better talk to somebody else. Or people who died on Pettus Bridge because, for us to have a right to vote. And you don't want to go and vote, even if you have to drive or whatever. That inspires me. I owe a debt of gratitude to the people who come before me. And I absolutely am determined to make this place a better place for the people who come after me. And I only work with people, and this is a tribute to all of you, I only work with people who want to get it done, not who just want to talk about it. But don't start here today, and then a year from now, hold us accountable. Ask, what did we do? What's the measurement? What has happened? What's different? If you're a part of this task force, I guarantee you, I won't be here a year from now if we're not actually doing something to try to help make, even if it's small steps leading to a bigger goal. Again, united in the common goal helps us to get to where we need to get to. So that's what inspires me, is those who come before me. All the people that I see and talk to are 1.3 million members, and hearing their stories, the Flint water crisis, my grass is being watered while people in Flint are trying to get, or Benton Harbor trying to get fresh water. I'll be daggone if I'm going to live in this world and not do whatever I can do to help. That's what inspires me.
Thank you. Ooh, and you've just sprinkled inspiration on all of us with those remarks. Mr. Taylor, why? What's your why?
Yeah, to make it as simple as possible is this, really want to make a difference in regards to really want to assist and to try to improve the lives of others. And as folks were talking, one of the things in which I thought about in my why is I've always had the opportunity to sit at the knees of older adults, whether it was my grandparents, my uncles or aunts and just other community members, and they just kind of take you in and kind of raised you and shared their morals, their values, life wisdom stories, and things that help as far as think about that, as a child or a young man, didn't know anything about investments, and folks come and tell you and sit down and talk to you about investments. Didn't even know anything about marital situations, and some conversations that I've had with some older gentlemen that's kind of, I'll probably say, helped my marriage in many ways. But one of the things which I kind of think about is that my why can also be related to, I'd sit back and think about some of the stories in which my grandmothers, my maternal grandmother especially, would share with me about her experiences growing up in the Deep South, and just some of the inequities that they've had to deal with and some of the injustices. And, you sit back and you kind of think about it, and you take a look, and you say in the early 1900s, the same circumstances or the same situations that they were facing at that particular point in time, we're still dealing with today, whether it's access to health care, whether it's having to travel miles to get health care, and whether it's, just the ability to feel comfortable or feel safe or feel like you're on par. And it's incumbent upon us at DAAA, and I'll say all of our other social service organizations, to really to meet individuals where they're at, and to, what I'll say, to recognize the value in each and every one of those individuals, and to be able to provide them the resources so that they can have a decent life, or to be able to maintain what's occurring. So my why is, one of the things I would also say is that I had a colleague of mine that when I first got here, and it was one of the most profound statements that I heard and that I try to hold on to dearly. And as we drive around, as we go around this community, and we take a look in regards to what we call the Snaggletooth neighborhoods, you may see, or you see some of the housing structures and what those housing structures look like, or it could be a great neighborhood, and you just kind of wonder, what is the circumstances, or what are those individuals dealing with behind that door, and what is life presenting them, and what can we do to help improve their life circumstances? And so it is our mission, and it is my mission, to try to be a change agent, but also to help individuals have the best quality of life in which they can have. Because as Ms. Cunningham said, folks paid it forward for us, and it's our job to pay it forward for the next generation.
I love it. I love it. Yes. Snap, snap, snap. And you acknowledged your predecessor, Mr. Bridgewater. It's so important to realize we're standing on shoulders of folk, and we're so happy that he's joined us this morning. This is legacy work. It's not one and done work, and we're in it for the long haul to get to the finish line and the fix. Dr. Smitherman, your why.
Yes, ma'am. I've been practicing now this year for 34 years. And I have seen more desperation in the numerous patients I've seen over my career. Children who are hungry that come to the practice, that we have to try to get food for them while they're in my office. Or the elderly man who we just saw who has schizophrenia, who was hungry. And before I could treat him, my staff went down the subway on the first floor to get a meal for him. Or the child in my practice who's in a home with her single mom, who there's a man in the house molesting her. And I can tell you the kind of desperation that I see layered on in the context of the poverty levels we see, meaning that people do not have advocates. There's no one in their life to protect them. I could not imagine sitting across from these people. And I'm now the person in that room who has no advocate, who has no one to help them. No one. I would hope that all of us sitting in front of these people would act in a way of ultimate protection, ultimate advocacy, and ultimate action. And that we would mobilize in a way to protect that person at every level. I can tell you the number of judges I've had to speak to in my life, or DTE members that I had to speak to get power on, or the water company to get water on in a family's home. Families that are without housing, and how we're trying to work with HUD or some other organization, or thaw or whatever, to try to get people warm, healthy, housed, fed, some transportation, et cetera, some kind of way to get an income, some kind of way to set up to get health insurance. It's just a travesty in a country this wealthy to sit around and have people, our children, our seniors, hungry. It is pathologic, I am telling you. And having that, being bombarded with that almost every day it wears on you like you would not believe. There is a lot of what do we call burnout in the medical community, especially if you put on the context of COVID. So I'm just saying this pathology has got to stop. We've got to do something different. We can't have these people in our country this vulnerable. And so I am interested in those of us who are doing great work in our own individual worlds, but sometimes we don't have the link to help the person in front of me. How do we create those links to get people where they need to be in an effective, efficient way so that we serve them better? So my why is, I would hate to be this person talking to me with no advocate, and the person they're talking to cannot help them. That is my motivation.
Man, gotta take a deep breath on that one. You know, I hear you articulating really some righteous indignation there, and what we call in one of our equity projects in my shop at MPHI, productive outrage. We went into our grant saying we want to create productive outrage. And I dare say that that's our mantra for this. What you have just described is like, how dare we sit back content with this situation for people's lives? And I will say that my own why, my grandmother lived to be 95 years old, close and dear to my life. I lost my mother early from breast cancer. And so my grandmother really mothered me as an adult. And I remember her saying to me once, "It's nice getting old, but it's a little inconvenient." And I chuckled because she had a great sense of humor. But the older I get, the more I appreciate what she said. This society is not structured for seniors. And the goal is that we would all become seniors one day. Right. So how do we work vigilantly, passionately, to make sure that our lives will be better? And I would say that it is also not just about, as a sociologist, this metric is not just about what's happening to seniors, but it is really an indicator of this society. Dr. Smitherman mentioned that. Just like infant mortality is not about babies dying, it is, but it's about what we value. The fact that aging seniors do not have strong qualities of life is an indictment on this country, and we aim to do something about it in Detroit. So let me just throw down the gauntlet to y'all. We are starting out on this journey, as Ms. Cunningham said, and we want you to come with us. We're going to talk a little bit at the end of the meeting about next steps, about what the opportunities will bring. But I ask you to think about who's not at the table. Look around, you can see who's in attendance, who's missing, who do we need to reach out to? And I am one who loves quote. So let me just, before I pass the baton back to Dr. Richards, share this Martin Luther King quote. And he said, I have the audacity, I love that word. I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education and culture for their minds, dignity, equality, and freedom for their spirits. And he went on to say that I believe what self-centered men, or I'll say people, have torn down, that people other-centered can build up. And I have the audacity to believe that we all on this call are those other-centered people that are going to build stuff up in this time, in our lifetime. So thank you so much to my colleagues, Ms. Cunningham, Mr. Taylor, Dr. Smitherman. I feel energized by the dialogue. I'm ready to go forth and do battle. So thank you so much. And for coordinating this, and Fiona, I'll pass the baton back to you.
Thank you, Dr. Cunningham, Dr. Kennedy, Mr. Taylor, and Dr. Smitherman for an energizing panelists. We're very grateful for that. In terms of next steps, if you noticed, we collected, when you registered for this event, we collected a little bit of your contact information. So in terms of next step, what we'll be doing is sending out further communication about ways to get involved and additional information in terms of what this task force will be doing. So I wonder if anybody has any questions about sort of like, you know, in terms of like next steps. We will be developing subgroups based on the social determinants of health, and we will be eliciting participation based on those. Philip?
Fiona, I wonder if it would be helpful for our participants to just go through these next couple of slides. Maybe you can walk them through, because it gives the overview of the structure from task force to subcommittee to strategic plan. So maybe that'll give everyone a better global view of it.
Okay.
Shall I do that and let you
Yes, go ahead.
illustrate?
No, go ahead. So in terms of the inclusive health care, the goal is to develop a community-wide implementation plan or roadmap designed to coordinate and integrate social and environmental determinants of health to reduce health disparities and to close the gap on the technology digital divide. So our objectives are to establish an inclusive healthcare task force consisting of public and private partners to develop a road plan map designed to better coordinate, integrate services. So if you notice sort of like a through line between throughout the panel was sort of this, how do we integrate services? How do we sort of collectively come together to do this? And to address the digital divide to reduce health disparities of older adults, caregivers, other city residents, and service providers. In addition to helping to develop a community-wide roadmap conceptual framework for connecting the community to technology, community resources, and the social determinants of health.
Yeah, and I know I might just put in there for all of us that the ultimate goal here for this phase of the project is to create a toolkit or a roadmap or whatever we want to call it, so that every single one of us can show up and just really quickly see where our part is in this bigger project, right? So this is designed to make sure to not leave anybody out, because as our panelists brilliantly said, it's going to take all of us to move us forward, right? And so we need to know, just without wasting time, where can we fit in right now? And that's what this toolkit is, or I call it a toolkit, what this roadmap is going to be designed to do.
And I'd also like to uplift Winona's comment about the participation of community members. So community members will be integrated in some of the subcommittees that will be developed outside of that. So we are sort of keeping community participation in mind as we sort of develop subcommittees. So In terms of additional program objectives, we are interested in researching the systemic technological changes needed within and outside of the provider network to better integrate care and develop the community's healthcare workforce. Second, to develop process and community impact methodology for evaluating implementation of the IHC Metro Detroit initiative. And finally, to develop a final report, as well as a toolkit to support program expansion and replication, including an inclusive healthcare summit. So what does an inclusive healthcare process look like? First, we're interested in establishing an executive and steering committee, as well as subcommittees of the Inclusive Healthcare Task Force. Second, we will create a structure for the subcommittee based on the 5 key social determinants of health domains, which includes social, economic, healthcare, neighborhood, and environment and education. The digital divide will sort of be the through line that will connect all these different sort of subdomains of social determinants of health. And third, we would like to bring together partners to develop vision to coordinate the social determinants of health to reduce health disparities.
And just before I advance the slide, so we all know, we are right now between number 1 and number 2. So it's an exciting time because, as Dr. Kennedy et al. Will be asking in a minute, we are now ready to, now we've been prompted, so we're ready to do the work. So we're between 1 and 2, and 2 will be the formation of these subcommittees. And I'll just advance the slide so Dr. Richards can read off 4 and 5 there.
Fourth, we would like to develop a community-wide implementation plan in collaboration with AARP Michigan and PHI, as well as other partners. Fifth, we are interested in the development of an implementation plan inclusive of metrics to measure outcomes, to capture collective impact, and, to borrow Dr. Kennedy's phrase, to induce productive outrage. So a little bit about in terms of what the structure will look like. So we have established an executive advisory council, as well as a steering committee and the implementation team. So through that, we will be working on creating the healthcare task force. And as I mentioned before, we will have subcommittees consisting of the different domains of social determinants of health. So again, that's the healthcare, neighborhood, economic status and retirement, social and community context, as well as an education domain. So in terms of prospective partners, we are interested in having consumers, corporations, government, healthcare organizations, public health, technology, experts, faith-based organizations, and aging organizations in partnering with us for this initiative.
And so just so we're super, super clear, everyone on this call is a de facto member of this task force now. You'll get a formal ask in a minute. But what our real deal is that we have to bring everyone we know on board now, right at this moment. So there are so many people that we all know who maybe they couldn't be here today. We have a recording of it. Dr. Richards and I are going to make ourselves super available for this next process. Lean on us so we can get that communication. Just tell everybody, because as Dr. Smitherman really, really points out, unless we all get involved, it's just going to be this continued, situation, which is untenable, immoral, and horrifying.
So in terms of our call to action, we invite you and everyone to join the Inclusive Healthcare Task Force as as part of a member organization or a consumer, to engage in our task force meetings no more than 3 times over the next 6 months. So what does it look like? In addition to that, you will be invited to participate in a work group designed to examine aging and the digital divide in one of the 5 social determinants of health domains that I mentioned, as well as put input in the creation of the forward-thinking roadmap through a strategic planning process. So the work group meetings will be designed by facilitators, as well as working with Elizabeth Whitaker Walker, who will be present in the strategic planning process as well. So these subgroup meetings are sort of designed to collect information and recommendations to bring to the larger task force. So as Philip mentioned, in terms of mentioning, thinking about other individuals who may be interested in joining or appropriate for joining our initiative, is we'd also invite you to consider an additional opportunity in terms of leading and serving as a chair of one of the 5 work groups, with the expectation that you'll be committed to attending the steering group committee meetings as well. So in terms of what we're looking for, inclusive healthcare partners are looking for consumers to serve on the inclusive healthcare task force. So targeted consumers include older adults, adults with disabilities, and caregivers. And a representative will be assigned to the inclusive healthcare steering committee and/or one of the 5 subcommittees to provide input into the development of the community-wide plan. So in terms of next steps, as I mentioned before, partners will receive an email to gather additional data on your organization representative. And if you cannot personally commit, we invite you to invite a representative or an alternate in your place for your organization if you personally cannot or unable to commit. And we will start appointing chairs for each of the subcommittee meetings, who will also be part of our steering committee meetings. And we have meetings scheduled for November, January, and February.
That's awesome, Diana. Thank you, Dr. Richards. So just FYI, if you get emails from Philip Barnhart at MPHI or Krishara Allen at DAAA, don't let them go to your junk mailbox, okay? Please. Dr. Kennedy, back to you.
Well, first of all, I really want to thank the team that have really made me and Ms. Cunningham and Mr. Taylor and Dr. Smitherman look so good today. It really is Krishara and Ann Holmes and Philip Barnhart and Diana Richard, who will be the ones moving things, keeping us accountable, making sure we're following through. We recognize that you all are very, very busy, and we all have lots of responsibilities. And so we want to make your engagement with us as easy as possible, right? It is a heavy lift, but we want it to be one that you feel supported in. And I would offer that you come to the table with the framework of not I have to do this, but I get to do this. We don't have to do this, but we get to. There's this sort of permissiveness of opportunity to say, I want to be able to look back and say, man, this really did make a difference. And we are absolutely committed. As Ms. Cunningham said, if we're looking back in a year and we can't say, look what we accomplished, look what we did, none of us are going to be here. I'm going to invite us all to run for the hills, because we are here to execute change and impact our own lives as well as the lives of those that we love. And so this is definitely a sounding the alarm moment. We know a lot, but what are we going to do a lot of together? And so if there are no other kind of last comments, I think we can kind of check the the chat one more time and see if that's clear, the things that Dr. Richards shared, is that clear for you? And I want to make sure that there's nothing else you want to add in. You've been so instrumental to getting us to this point. She's like, don't call on me. I see you.
Well, I want to make sure that we had an additional question from
Okay.
Sarah Gold, but I'm not sure if they're still in. They're still here. But in any case, they asked, we at the United Way have begun to work on bringing the model of community information exchange, person-centered care that links social and clinical care, as well as social determinants of health domains through one another through collaboration and data exchange. We are also looking at the state SIM models and successes and challenges revealed there. Are there other models that the panel is looking at currently to inform this work?
I think that those are wonderful models that have been listed, and we're all at this table because none of us are the unique experts, right? And so this is an opportunity that we can look at together. Paula's putting down the 211 model. So I think looking at where are the overlaps, what are the synergies, what are the strengths of each of the models that we bring together in our own responsibilities and then in our collective responsibility. 211 is a huge. Is there any other that that anyone else is aware of, even in attendance today?
The Detroit Area Agency on Aging has been a part of the partnership that's looking at the United Way, a community information exchange, and that's definitely one of the tools that we need to examine as we move forward.
About the Alice model that is common in our United Way. So there are a number of frames. We don't want to waste time reinventing a wheel if there's one out there that's gonna work for us. So great.
Hi, Dr. Kennedy. Yeah, one quick question. Is there an infrastructure or planning grant for sort of establishing the infrastructure for this task force? Are there resources to actually fund the task force itself, independent of the different organizations, but actually the task force?
Anne, would you say that the Health Endowment Fund that we have is that sort of initial infrastructure resource?
Yes, currently the Michigan Health Endowment Fund is providing the Detroit Area Agency on Aging with a grant, a planning grant that is facilitating this discussion that we're launching today. And it is our hope that after we develop our community-wide plan, that we will go back to the Michigan Health Endowment Fund, as well as other resources, and get implementation funding. So we're very thrilled that they are partnering with us and making these resources available.
And I thank you. That's such a great question, Dr. Smitherman. I would also add that I think the Health Endowment Fund has a wonderful track record of following through with their early investments. So if they do a planning grant, our experience has been it's because they see great promise and want to continue to support the effort. So, yeah, money does make the world go around. We want to have some capacity to execute on what you all are going to create together. So thank you for that question.
Thank
Lots
you.
of, I was just going to comment that were we in a conference room together, we would kind of be stretching now and going around and shaking hands and hugging. But I do want to reiterate for you to check out who's in attendance today. There are lots of really important partners, many of whom I know, many of whom I'm looking forward to knowing. But this is about relationship. Relationships are primary, all else is derivative. My mentor says we only create things through relationship. And so we're honored to be starting this relationship journey for the good of those share this interest and commitment to aging adults. So Diana.
Thank you all again for convening with us for this launch of our task force. And again, as I mentioned before, you'll be hearing from us through email communication. We will also be sharing the Zoom link. I need to double check on the if we're able to share the PowerPoint, but if so, we'll also provide that as well. So again, if as Dr. Kennedy mentioned, like start thinking of individuals who aren't in this room and bringing them to the table. We're in the thick of recruitment right now. So again, I appreciate you all, and I hope that you all have a wonderful rest of the day. Thank you again for attending, and thank you to all of our panelists. Thank you to DAAA, MPHI. Thank you, everyone.
And we will, Dr. Richardson and I will stay on for a couple of minutes if it's okay, Fiona, to answer any remaining questions. And for those of you who would like to stay on with us, Anne or Krishara, other than that, yes, have a great day.
Philip, can you stop recording?
I can.